All right, so the elbow. We'll just talk about a little bit about the anatomy. Some of the big things you probably read about or heard about: lateral medial epicondylitis, little league elbow, avulsion fractures of the elbow, ulnar collateral ligament tears, distal bicep ruptures, and dislocations of the elbow. Actually, some of the earlier elbow studies were actually done on javelin throwers, and that's where they found out a lot of the problems with elbows, particularly in ulnar collateral ligament injuries. I think it was first described in javelin. Anyway, here's some basic anatomy in the elbow. Basically, lateral epicondyle, medial epicondyle, radiocapitellar joint, ulnar humeral joint. Very basic anatomy for you guys. Okay, so as far as the capsular structures within the elbow, some of the main ones you want to think about are the lateral structures here. You got the radial-collateral ligament here, which goes from the radius to the epicondyle, lateral epicondyle. You got the ulnar collateral ligament, and these are the views that you want to look at here. So the ulnar collateral ligament actually has 3 bands. The main band here is the anterior band. It actually splits into an anterior, inferior, and anterior posterior band right here. And then you got a transverse band, you got a posterior band. This is the main one that all the pitchers are injuring right up front here. Here's the radial-collateral band, and then you got a ulnar band, a lateral collateral ligament right down here. Those actually help stabilize the elbow. This is just some basic pictures here. The anatomy. There's your radial-collateral ligament, and this is an ulnar band of lateral collateral ligament. Have you ever heard of posterolateral instability, where the elbow, where the radial head pops out a joint out to the side? That's because this little band of tissue here is disrupted. Sometimes we see patients that have had tennis elbow surgery or lateral epicondylitis elbow surgery, and the doctor, I guess, will cut this ligament down here and basically create an instability in the elbow. So we actually go in there and reconstruct this little hammock-like structure right here to kind of cradle that radial head so it doesn't pop out of joint anymore. This is the ulnar collateral ligament. Once again, this is that anterior bundle that we were talking about. This is the Tommy John. This is the area that we reconstruct for Tommy John procedure. So right here. As far as the biceps and the musculature around the biceps, you got your biceps brachii muscle here. You got the biceps tendon here. This is lacertus fibrosus coming over here. This is your pronator, flexor mass over here, extensors over here. Just some basic anatomy. A lot of times, if you see a patient that they say they pop their biceps and they come in and they've got usually you think you're going to see a deformity in their biceps. Like I said before, look at symmetry. Sometimes they look symmetric. Well, what you do is a supination stress test. Have them supinate their arm to resistance and see if they have pain, and look for that bicep, see if it raises or lowers. If it doesn't do that, then what's happened is that the biceps is ruptured and it's retracted, and this lacertus fibrosus here, this aponeurosis here, is still holding it down. So you can actually have a detachment of the biceps, and this little band here is still attached. So if that's the case, you can actually be looking at a patient, they look okay, but they actually have a detachment of their biceps. So an MRI would be indicated at that point to kind of confirm the diagnosis. Once again, when it comes to assessments, look at the history, past history, mechanism of injury, when and where does it hurt, motions that increase or decrease pain. Does it hurt you to rotate a doorknob? Does it hurt you, do your backhand, your tennis? Type or quality of pain. Do you feel any numbness and tingling in your fingers when you have any of these symptoms? How long have you been disabled? How long has it been going on? Swelling, previous treatments. Do you have any clicking or popping in the elbow? Look for any deformity in the elbow. Look for any asymmetry, any swelling. Look at the carrying angle. Sometimes you see a patient come in, and especially kids, have them drop their arms to their side and look at their angles. Sometimes if they've had a growth abnormality, you can have a varus arm on one side and no normal arm on the other side. So that can actually predispose somebody some injuries in the elbow. Also look at their flexion and extension as well. Palpation, once again, just go through the basic bony anatomy here, palpating these major structures, soft tissue and bony. Looking at the assessment, as far as the special tests on the elbow that you want to think about, circulatory and neurologic function. I can't tell you how many patients I see that come into the office that say that they have elbow pain, but actually they're suffering from cubital tunnel, which is actually the ulnar nerve being impinged or being trapped in the cubital tunnel. and actually giving them symptoms in their fingers, but they think it's elbow pain because it kind of starts in this area. It's not necessarily the elbow, it's their nerve. It's an issue there with the nerve. So look at the pulses, make sure they've got good neurovascular fill, or a good capillary refill. Neurovascular exam should be good. Do a Tendon sign, like I mentioned before. This is the ulnar nerve test. We just tap on it a couple times. It feels like you bumped your funny bone, and it radiates down to their 4th and 5th fingers. That's a positive sign for Tendons. So let's see. The varus valgus stress test. This kind of helps only if you have a pretty severe elbow dislocation. If you have these patients that have very mild laxity in their elbow, it's not going to show up too much. But I think what you really want to look for is really pain as opposed to laxity. Okay? So if you have any pain with the varus stress, pain with the valgus stress, that will indicate a little bit more about what's going on with the elbow joint. Functional evaluation, pain and weakness, evaluate through active and passive range of motion. How much can they move on their own? Look at their flexion, extension, pronation, or supination. Particularly their rotation, their pronation and supination, whether or not they have pain with any of those motions. Lateral epicondylitis, these are overuse injuries, so they're chronic. Also known as tennis elbow, usually occurs with degeneration at the extensor carpus radialis brevis. That basically the tendon and muscle tendon unit that inserts the lateral epicondyle. A lot of this can be occurring because of poor technique, either swing, wrong grip, wrong racket size, poor string tension, localized pain with resisted wrist extension. I like to do what's also called a piano key sign. I have them extend their elbows, flex or extend their finger and their elbow, and then push on this 3rd digit, okay? Because that's where ECRB inserts down distally around here at the base of the metacarpal. So if they have pain when you're resisting on that 3rd digit, and it irritates the lateral epicondyle in this area, that's a positive sign. Another sign I have them do is the handshake test. I have them shake my hand and then bring their arms slowly into extension while squeezing my hand. If they have pain, then that's another test that actually indicates lateral epicondylitis. And then, of course, if they have localized tenderness with palpation, you want to look at other things to look at. Make sure you're not having any issues with biceps. Look at their supination or resistant supination. If they have that as well, then that is more indicative of distal biceps pathology. As far as treatment for lateral epicondylitis, the majority of lateral epicondylitis is treated non-operatively. A lot of these can actually burn out over a period of 6 months or so, and there have actually been some very promising studies, and Adam could probably refer to this or talk about this afterwards in regards to PRP and lateral epicondylitis. But I usually start with a typical algorithm involving a counterforce brace, stretching, strengthening activities, as well as doing some deep tissue massage and cross-fixure massage at the tendon itself. Things like ultrasound and heat and ice are also helpful. Cortisone injections, I usually will do 1 or 2. I don't like to do a lot of cortisone injections. Cortisone is not necessarily good for the body. If you do a lot of these injections, they can actually discolor the skin, can actually weaken the tendon. But I believe it's okay for maybe the first, they're just getting that patient jump-started to start the therapy, do the rehab. So I think it's helpful for pain at that point. If they failed with 2 injections and extensive therapy, and have had tennis elbow for at least 6 months to a year, that's when we actually start talking about something surgical. And I do these arthroscopically, so we actually go in there with a scope. We debride the degenerative tendon and actually repair the defect arthroscopically as well. Occasionally I do these with a mini open, and I only do that if I have involvement of the collateral ligament, the radiocollateral ligament, because that's a structural defect that I want to repair as well. So I'll do that through a mini open. But the majority of these are done arthroscopically. But like I said, it's very, very rare because that people would need something surgical done, because most of these are treated non-operatively. But we see a fair number of elbows. I have done a few of these as well. Medial epicondylitis, also known as golfer's elbow. It's on the inside of the elbow as opposed to the outside of the elbow. It's less common, a little bit more difficult to treat. It affects the pronate or teres flexor carpi radialis interface. So this whole flexor wad here on the inside of this elbow inserts right there at the medial epicondyle. Treatment is the same as lateral epicondylitis. However, if you're going to inject this medial side, be very careful, because some of these patients will have subluxating cubital or ulnar nerves, that actually can't subluxate into the waist. You want to palpate that nerve, know good and well that nerve is, because if that nerve subluxates right in the area that you're going to inject, you got to be very careful. But nowadays, with ultrasound technology, you can avoid a lot of these problems. Little league elbow. These are more for kids and young adults that are still have open growth plates. And this is osteochondrosis is for the younger kids that you see, where they actually have fragmentation of the cartilage. It's called Panner's disease. The majority of these are self-limiting. They actually burn out. They actually heal up pretty well. And we're still trying to figure out exactly why. I think it has to do with the vascularity and the growth plates of the kids. But however, when you start getting into the older kids and the teenagers, they can develop what's called Osteochondritis Dessicans, where they actually have fragmentation of the cartilage due to a vascularity issue. It's usually due to overuse and overloading of the radiocapitellar joint. Can involve the ulnar trochlear joint, and you can have a patient show up with acute pain in the elbow caused by repetitive trauma. Or sometimes these fragments can actually dislodge and float into the joint and cause a locking sensation or catching sensation in the elbow. And if that's the case, then I know as far as treatment options are concerned, those little fragments don't disappear, so we actually have to arthroscopically remove them. And for these kids, what we've been doing is actually doing an osteochondral transfer for these large defects that they have, because the fact that we've seen that if you just take that piece out and leave that big crater alone in that cartilage, what we've found is that these kids develop early onset arthritis, and so what we are doing now is we'll take a chondral plug or a cartilage plug, sometimes from the knee or sometimes from a donor, and actually use it to plug up those defects to actually give them a normal cartilage surface. And I've had patients that have gone back to pitching and throwing and back to their sports when this used to be actually considered a debilitating diagnosis. Anyway, little league elbow. Localized pain. A lot of times the patient presents with a flexion contracture, like an inability to fully extend the elbow. And that's usually due to capsular inflammations. Don't get too worried. A lot of times this will actually get better on their own. But you got to shut these kids down, and you got to explain to the parents that you got to stop throwing. You got to stop going out there and playing baseball 10 days a week, 7 days a week. And that's the hardest part of my job. But still, they just have to understand what's going on. Their growth plates are immature. They haven't ossified. So that makes them an easy target for these high stress forces across them. So the first place that they're going to injure is their growth plate. So you've got to be careful about that. This is what a typical patient will show up with. Extend, like I said, look at symmetry here. Straight arm, flexed arm, a good flexion here, but you can't extend all the way. So something's going on with his elbow. It could just be an inflammation. It could be a loose body. You got to do some further diagnostic tests to see what's going on here. Treatment, early stretching, ice, and rest, avoidance of throwing, counsel the overachieving of parent. Like I said, that's the hardest part. Continued throwing can cause further fragmentation, permanent deformity, and cubitus varus valgus deformity. And I think once you educate, I think education is the key here. I think once you educate the family, you educate the patient and his family and the parents, they understand that if you keep throwing, it's going to cause further damage. Most of them actually will follow the instructions. Osteochondritis Dessicans, loose bodies, may develop if you do not shut it down and let things heal up appropriately. Osteochondritis Dessicans, I apologize for this slide. It's kind of crazy, but just really in a nutshell. Like I mentioned before, it's a problem with blood supply that leads to degeneration and fragmentation of the cartilage due to repetitive movements across the elbow over time. Seen in young patients, they're usually throwers. Panner's disease, like I mentioned before, these are usually in kids less than age 10. That actually resolves on its own. Patients will present with locking, pain in the elbow, swelling, decreased range of motion. X-rays can show a flattening of the radiocapitellar joint, particularly the capitellum with some loose bodies in there. Management, activity restriction for 6 to 12 weeks. Sometimes you can get these to heal up. Kids, the great thing about kids is that they've got great vascularity and they can actually heal. But you got to let them rest it and let them heal. Anti-inflammatory is good. Splinting, casting are good to keep them shut down. So I mean, if they won't listen to you, I just put a cast on. You can't take that off. But if repeated, if they continue having symptoms, then you're going to have to discuss something surgical, like removing the loose bodies. Okay. This is what it looks like arthroscopically and on radiographs. Okay, MRIs here, you can see the deformity right here, this black circle around here. That's actually dead. That's just avascular necrosis, or basically Osteochondritis Dessicans, which means there's no vascularity in this region here. This is an area that's kind of lighter on this X-ray here, and this is what it looks like arthroscopically. These are loose bodies in the joint. This is what we look like arthroscopically in the joint. We actually see in the joint here. This is a big loose body. Sometimes we go in there and see, a couple little fragments that were taken out. Sometimes we're taking out things, but look as big as M&Ms or Easter eggs. So, I mean, there's some big loose bodies that are out there that we got to take out sometimes. So, fractures of the throwing athlete. These are avulsion fractures. Usually occur due to the high tensile stresses across the medial epicondyle, medial side of the elbow. Usually across the collateral ligaments pulling on the growth plates. It can actually cause a detachment of the epicondyle or a fracture of the epicondyle. This is what it looks like. Patients will show up with pain, tenderness, and decreased motion. This is the fragment here that's been pulled off because this growth plate was overstressed, because they didn't rest and they didn't listen to the fact that the elbow hurt, and they didn't splint it or protect it for a period of time and let it heal up. And if they keep on throwing, this is what can happen. The treatment for this just depends on where the fracture is. Usually, we have to put a screw if it's down here at the base of the ulna, approximately, or if the medial epicondyle, depends on how much displacement. If it's completely displaced, we have to put a screw across it. Ulnar collateral ligament of the elbow. This is basically the typical injury for throwers that we see a lot of. Result of the valgus stress across the elbow. You can see here the elbow's going one way, the arm's going the other. This is the stress in the medial collateral ligament right here, the ulnar collateral ligament of the elbow. Like I mentioned before, that anterior band that we showed is the primary restraint to the valgus stress across the elbow. Patients report pain and laxity with valgus stress testing. Usually if it's an athlete, they'll come in, they say, my velocity's dropped, I got significant pain in the medial side of the elbow, or they'll be throwing and they'll feel a pop or a snap on the inside of the elbow as well when they present. So those are the things you want to think about. Treatment is reconstruction of the ligament after failure of conservative measures. Now that all depends, once again, on the patient, their expectations, and the type of tear that they have. If it's a partial tear, the majority of these do great with non-operative management. And Adam would be great to talk about with ulnar collateral ligaments with PRP, because I think there's some studies that talked about PRP injection for these partial tears, and they're actually showing some pretty good results. For full thickness tears in a high velocity throwing athlete, if these guys want to keep playing, they're probably going to need a reconstruction, which is the Tommy John. And this is what we do in a Tommy John reconstruction. We take a ligament. A lot of times we take the palmaris longus, which is on the opposite hand, which is the tendon here. We actually use that. We weave it through some tunnels here on the medial side of the elbow, and then tie up the native ligament back on itself. So there's a number of different ways of doing this. This is just one way, but it actually gives us back a stability in the medial side of the elbow. Bicep tendon rupture, rare. Yeah.
On that ulnar collateral, what kind of time frame do you shut them down for? What's the,
If it's a partial tear?
Partial.
I put them in a brace, a hinged brace immediately, have them no throwing at all, and wear the hinged brace for 6 weeks.
6 weeks.
And then after that, I'll say that they can take the hinged brace off. They can do batting only. No pinching yet until looking at about 10 or 12 weeks. But I have them start like a thrower's 10 program for another 6 weeks. So it's a total of healing about 12 weeks.
Okay, we just had one that was like 6 months.
Yeah.
They shut him down for 6 months.
I've usually done it. Depends on the tear and the size of the tear. But for partial tears.
Growth plates that do and all that.
Yeah. So usually it's been about 12 weeks. Usually I've seen across the board. So bicep tendon ruptures, rare injury, peak incidence between 4th and 6th decade of life. We see a lot of these as well, but they are rare in the general population, general orthopedic surgery practice. More common in the dominant arm. Due to a strong extension moment, basically, I see these in a lot of patients that are grabbing things. You're reaching for a printer that's about to grab on the floor, you supinate the arm, extend it, and you're flexing. And that, all at once, with stress on that distal biceps, will cause a pop and actually cause a rupture of the biceps. Defect may be palpable, sometimes it may not, depending if that lacertus fibrosis is intact on the medial sides. Sometimes you may not see a palpable defect. This is key here, weakness with elbow flexion and supination. So if you have them resist you, put your hand on the wrist, have you resist them with supination. If they hurt, and then they hurt when they flex, then that's indicative of an injury. Usually it's a pull off the tuberosity. Treatment for complete tear depends on the patient, okay? So, I mean, if you're an active patient, you want to get back to weights, you want to get back to weightlifting, and I have a lot of patients that are active and they want to get back to their sports activities, I usually fix them. But I also have patients that don't do a lot. I have patients just work in their garden, or maybe one of their big day is just getting up and turning the TV off or something like that. So, I mean, you don't have to necessarily fix these. I mean, this is not going to hinder the ability to reach out and grab something and do your daily activity. It will hinder the ability to give you our strength with resistant supination. So if somebody that wants to work with tools for a living, or as a workers, just say does a lot of heavy lifting. I had some bodybuilders that did a lot of this, or had this happen, and they had to get back to their weights. We have to fix these. So restore supination and flexion. There was a study in 1960. This basically reports a threefold increase in disability for unrepaired cases. Morey in 1985 reported only 61% flexion strength and 65% supination strength in unrepaired cases. So this shows you how much of a deficit in strength there is if you leave them alone. But with repair, you can get up to 95% of your strength back. And I've seen these, and the key with these is to treat them early and diagnose them early. If you don't treat these early, they will retract and they will scar, and they become very difficult to pull back down. And I do these on chronic patients. I think the longest one I've done with a patient was a year out, and his biceps was up here, but we put an Achilles graft from a cadaver, span the biceps and go back down to tuberosity. Now he's got good strength and motion. He was doing this because of work, so he wanted his strength back, so we were able to fix that. This is just basically what a tendon rupture looks like and how we fix it. This is the tendon rupture here. This place, this is actually some sutures running through it. This is actually running it back down to the tuberosity here. So, dislocation of the elbow. This basically occurs with falls, traumatic injury, a fallen outstretched extremity. Bones can be displaced backward, forward, or sideways. You can distinguish this from a fracture just on X-ray, because you obviously look for your alignment. You see your radial head obviously laterally, or your ulnar humeral joint medially, and they're not lining up appropriately on their lateral reviews, and you have a dislocation. Just want to make sure that you reduce these immediately if you happen to have it, or call your local orthopedist. Severe pain, swelling, disability, patients not able to move their elbow at all. Complications of this could include median radial nerve injury, sometimes blood vascular injury, often radial head fractures are involved. Like I said, refer for a reduction if it happens. Neurologic and vascular exam are key. You want to make sure you get a good exam before and after if you're doing dislocation. Reduce immediately, immobilization. Nice thing about elbow dislocations, a lot of people think if you dislocate your elbow, you need surgery immediately. If you don't have a fracture, the majority of these actually heal up within 3 weeks and stabilize. And then you put them in a brace, and the ligaments will actually heal up beautifully. I had a wrestler that had this happen to, complete bad, horrible dislocation. We popped her back into place, put her in a hinge brace. She ended up going back to wrestling and got a scholarship and did great. So, I mean, it's amazing how much the body can actually heal. And like I said, Adam can probably add to a lot of this stuff I'm talking about regarding PRP and how much of a play this is going to have with some of these things in the elbow. Range of motion, strengthening is 6 to 12 weeks, from return to sport about 4 to 6 months. This brace I usually use. Actually, it's a little bit more lower profile than this, but this is a hinge brace, and this is what we use for the ulnar collateral ligament partial tears as well, or if we're going to protect them for a period of time. So they're able to move their elbow, but it keeps them from over stressing the medial aspect of the elbow.